On behalf of RSNA, welcome and thank you for joining us for today's webinar, Radiology Workflow Orchestration, More Than Meets the Eye, sponsored by AGFA Healthcare. This webinar is one of the many ways that RSNA and its valued partners support radiologists at every stage of their careers by offering educational resources and tools to increase knowledge and foster innovation. After the presentation, there will be time dedicated to answering your questions. We want this to be an engaging and interactive discussion, so please share your questions by typing into the question box, and the speakers will respond during the live Q&A portion of the webinar. If you have any questions for RSNA, please email customerservice@rsna.org. Thank you.
Welcome to today's webinar on enterprise workflow orchestration. As we find our way through an ever-evolving world of workflow optimization and efficiency-centric healthcare design, it brings many opportunities to rethink the way we do work. I'm Paul Lipton, the Global Solution Manager for Radiology and Clinical Viewing for AGFA Healthcare's Enterprise Imaging product line. I am an advisor to the HIM-SIM Enterprise Imaging community, and I will be moderating the conversation of my esteemed colleagues who will bring valuable insights to the challenges and opportunities that arise in an ever-evolving world of imaging and healthcare IT. I'm pleased to be joined today by Dr. Nicholas Spencer, a consultant radiologist with the Mid-Yorkshire Teaching NHS Trust and Clinical Chief Information Officer of AGFA Healthcare, and Dr. Cheryl Petersilge, visiting clinical professor of radiology at UPMC and president and founder of Vidagos, an enterprise imaging strategy firm. Welcome. Dr. Spencer and Dr. Petersilge, please introduce yourselves.
Hello, and thank you for the invitation. It's a real pleasure to be here today. My name is Nick Spencer, and as Paul outlined, I'm a radiologist in clinical practice with a long career in the NHS. I studied at Leeds University and undertook an elective at McMaster Medical Centre at Hamilton, Ontario, and during my radiology training, undertook a fellowship in oncology imaging at the Christie Cancer Centre in Manchester. I've had a varied career with leadership roles and centred around running oncology services in my institution, but more and more focus has centred around IT-driven workflows. And I'm now in the position as Chief Clinical Information Officer at AGFA Healthcare and also sit on AGFA's Clinical Advisory Board. So it's a pleasure to be here today.
Hi, I'm Cheryl Petersilge, and as Paul mentioned, I'm still a practicing radiologist. Musculoskeletal radiology is my specialty. And I have an enterprise imaging consulting firm, and I came at my informatics career through a start in clinical informatics, where I helped with CPOE and electronic documentation and really got to know a lot about the electronic medical record side of the electronic health record. And then I moved over into imaging informatics, where I worked at the Cleveland Clinic in conjunction with AGFA to help start the enterprise imaging program there, that to this day is still recognized as one of the most comprehensive enterprise imaging programs in the United States and probably globally. And so I really had a chance to work with some great leaders in the enterprise imaging field and to help inform a lot of what's going on in the enterprise imaging industry today. In addition to that, I have what I would consider a fairly broad perspective on the practice of radiology. I've chaired several different hospital radiology departments, and I served as the vice chair for the East region for the regional radiology practice at the Cleveland Clinic. So a lot of work managing radiologists across geographies and across different specialties. And so that really helps inform my perspective on what are the needs of radiology and imaging in today's world.
Thanks to both of you. Very impressive backgrounds. I'm excited to get into the conversation. Dr. Spencer, we need to review the need to orchestrate. What is your definition of orchestration? And take us through the journey of where we are today in terms of optimizing radiology.
Yeah, that's a really important place to start. I've seen, as Dr. Petersil's described, a major evolution of radiology services as a whole. And the growth in radiology has been massive over the last 20 to 30 years, really the era of advanced imaging. And I think we've now moved into the era of workflow management, which is really what orchestration is about. And of course, here it gets a little bit more complex because we've got to consider ever more different types of patient, a multitude of institution types, a variety of clinical settings where imaging is acquired and the results are analyzed to fit in with patient care. And so orchestration means many things and quite different things in different settings. I think we can look at things along an imaging journey from the ease of referral, matching the patient with the record, getting the imaging done in the best place and at the right time, and making the results accessible. So all of this is just common sense. But what we're trying to do is make sure that the radiologist has all the tools at their disposal to create the best report possible, and that those results and the access to images will be available for the clinician and increasingly for the patient as well. I know that what I've just said sounds like a broad overview of service, and some consider the orchestration piece to be focused much more on the radiologist and actual consideration of reporting. I'm kind of guessing that my perspective in part comes from the fact that I've worked in the NHS for most of my career, and in that time been responsible for managing radiology services and how things work. So let's take a bit of a deep dive into radiology optimization. Orchestration at specialty reporting level means getting those correct studies in priority order to the right radiologist. Curation may be done in relation to scheduling, making sure that the radiologist on shift is the right person. Ensuring follow-up imaging is read by the same radiologist, all these sorts of things. And then the same principles apply to peer review workflow and management of oversight and outputs is really important for SLAs, so the service management team. So the breadth of this is really very considerable, and the possibilities for orchestration in radiology alone are almost limitless.
Cool. So when I think about this optimization, you're really broadening the term a little bit. And Dr. Petersil, do you kind of mirror what's going on here, or do you think that there's some differences?
Oh, no, I think that we are experiencing all the same challenges, both in my current practice and in my previous practice. As our experience, we were consolidating work lists across multiple different organizations, which is a trend that's going on, across the United States, but I think globally as well, so that we can take better advantage of subspecialty trained radiologists and the expertise and still maintain that local presence. And so we're really trying to meet many different masters so that we keep the practice of radiology as robust as it can be. And in the past, we've had to rely on either sophisticated filters or people moving between different lists, checking for the case that they need to be reading, or we ask for our our technologists are calling and telling us, okay, you need to read Mrs. Smith over at, hospital down the road where you're not reading. So lots of challenges that have been dealt with in a very manual fashion, which I believe really contributed to the complexity of the situation that we're now trying to solve. And the beauty of what we're doing is we're using technology to replace a lot of that manual effort in a way that makes us more efficient, makes us more automated, so that everyone in the imaging chain can go to that practicing at the top of their license, right? Our technologists can be imaging patients. They're not trying to track down the right radiologist. Radiologists aren't opening cases that really aren't meant for them. They're opening cases that are meant for them that they can read and complete and not wasting time. So when everyone gets worried about AI, I think this is one, and we'll use the augmented intelligence version of AI. This is where we're going to see great gains for radiology as a specialty, helping to make us more efficient, more effective. And I believe when radiologists and our technologists are freed up from some of these repetitive tasks, we can become better partners with our clinicians in caring for the patients. And we can extend some of our tools to them, but we can also extend our communications and our interactions to them for the betterment of our patient care.
So, Dr. Peterselge, as we think about that betterment of care, it's an important thing for us to think about how we look at our own jobs as well, and how we can really utilize that to not only improve the care, but also improve our quality of lives as the people providing that care. And I guess the real question for me, and Dr. Spencer, maybe you have some comments here, is how can real-time analytics and other types of intelligent orchestration help solve some of these care challenges and some of these personal challenges?
Yeah, I think real-time analytics are important, and they're there in the background in many settings. And I think that some of that is going to be dependent on local geographies, and also influenced by the evolution of imaging networks, which is very collaborative in the UK, and Dr. Peterselge outlined the coalescence of practices in the US, but there may still be a more competitive and immediate requirement in the North American market. I think real-time analytics are already embedded to make acute hospitals work and maintain patient flows. In the acute setting that I work in, there are bottlenecks in patient flows. The operational team have real-time monitoring to know what's going on with regards to numbers of patients arriving in the ED or the planned care unit, the number of empty beds and when they're predicted, and so on. And they're actually the people that are calling up to radiology to unblock some of those bottlenecks. So I use that as an example outside radiology because I think there are parallels inside. So constructing radiology exam lists, which can be done in automated fashion to reduce coil changes in the MRI, to make sure that the right category of patient that are all ambulants are coming consistently through CT to get patient flows. And then the orchestration piece that works after that is as we've already alluded to, which is getting the right study to the right radiologist at the right time. And I guess what we're trying to do is introduce this concept of smart radiology. And I think it goes beyond that, because business intelligence tools can in real time monitor waiting times from referral, scanner throughput. They can monitor radiologists' reporting volumes, and of course, may be aware of who's available to flex capacity once we're looking at scheduling. So this has many, many facets, and I think there's much further to go. And if we think about some of the tools that are emerging in products like enterprise imaging, that their applicability in a smart workflow is going to be ever more.
And we know that there's just daily operational challenges. I might be the stat reader, and a clinician came down to ask me about a complex study that I read yesterday. You know, I want to give him my expertise and my time. And by being able to monitor the list and know that even though I'm supposed to be reading stats, somehow they're backing up. We don't need somebody monitoring the list. The technology is going to be monitoring the list and shifting those patients that need to be read over to someone who is currently available. So it's not just the global work, it's that minute-to-minute work where we can also see challenges. And that's really stressful when you're that radiologist and you know you're supposed to be reading stats and you've got somebody in your office. How do you balance that time? But you can rest assured if you know that in the background, someone is going, somehow that work is going to be redistributed so that we don't have the bottlenecks that Dr. Spencer just talked to. We don't have the ED wondering why Mrs. Smith's head CT hasn't been read. And then on top of that, in a minute by minute fashion, we could be reevaluating the priorities in those work lists, especially as we start to incorporate more and more AI into the presentation of the images, the pre-assessment. We know about the stroke recognition or the pneumothorax recognition. And so that becomes more valuable when it can influence how the studies are presented to the radiologist. And we need technology that can incorporate all that information in. We don't want me going back to the work list to look and see in the 5 minutes I took reading the other case, did something more urgent arise?
There's another facet to that as well, around residents and trainees, because there may be a co-author workflow that's going to work more efficiently and effectively, that will enrich their training, enhance their supervision, and ensure studies are reported in timely fashion. So it's all of this has got potential to be a win all round.
We've discussed some of the various roles involved in radiology. We've talked about the radiologists being able to optimize their work. Maybe go into a little bit more detail on how the radiologists can optimize their work during the day. Dr. Spencer?
Sure. I think quite a lot of what we've talked about is very much about making the whole service more efficient and focused and productive and all those kinds of things. But we've got to remember that our radiologists are our key asset. And we need to make their lives easier as well. So the ability to have communicator tools on the desktop that allow a radiologist to send a URL link to the work that they're reading at the moment, to ask their colleague or friend that they want to clarify a finding. The addition of precision reporting tools, templates, and things like that help with creating reports according to frameworks like BIRADS and PIRADS and so on. All of these things are really important. And as we look forwards and the radiologist is faced with multiple AIs potentially, it's really important that those are embedded in their workflow, that they don't distort priorities, that they don't have to go out looking at multiple other screens. So I think there's development that needs to occur that will make sure that the radiologists' experience interacting with the systems is also optimized.
Dr. Petershill, do you have any thoughts?
I do, and really, back to the first point Dr. Spencer just made, communication and collaboration are really two items that I think are very critical. And actually, if we talk to a lot of radiologists, we'll say we kind of lost that when we went to PACS, right? Because our clinicians stopped coming around. They didn't come down. They don't come down. They don't round. And it also made it a little bit harder as we started to read in our offices and not in these giant reading rooms to even collaborate with our colleagues. So I know one of the tools that I used a lot in the viewer is the chat with your fellow radiologist. And what's beautiful about that is I don't even have to be in the same hospital. I just have to be logged in and they have to be logged in, and I'll know if they're logged in or not. And I can send them a message and say, please look at Mrs. Smith. They can acknowledge they got it, but they don't have to stop right then and there, right? I know they got my message. They can finish their work. They can automatically open up that case, look at it, send me a message back, or if they're so inclined, they can call me. But it's another way that we're just making this workflow seamless. We're not having to stop, look up somebody's phone number, call them, interrupt them in the middle of the work. And now I understand that, and we were asking for this a long time ago, is to be able to have that same type of interaction with my clinician. Instead of going, go to image number 32, upper right-hand corner, see that black spot, what do you think that is? And we're assuming we're looking at the same black spot, but if we could mouse share or do other kinds of things so that now we can have that interaction again, and it doesn't have to be face to face, but we can still talk to each other. We can communicate in real time. We can make sure we're talking about the same thing. Again, going back to my concept of having the radiologist really become a greater part of the clinical team, I think is so important. Similarly, if my ultrasound technologist is in the middle of doing a case, do I want them to either leave that patient alone in the exam room and come down, show the images to me, have them ask me, do I want more images? If they could do the same thing, send me the images, send me a note, I could say, give me a minute. And then when my time is free within reason, and I can go back, review those images, and again, call them or send them a message back about what I need them to do to make a high quality case. Again, we've made the technologist more efficient, we've made me more efficient, and we're providing higher quality care with less effort. And that's a beautiful thing. And that's what we're really striving for across the industry with technology and automation and making that part of our daily lives.
So when we think about this, we're really talking about a broader enterprise win all around for everyone. Are there some other thoughts in this space outside of radiology? It sounds like your jobs and everybody else's jobs are going to get a lot easier, and care is going to become a lot higher quality and more timely. But are there other areas we can embrace with this? Cheryl, specifically, we work in the HIMSS-HIM community. There's a lot of things that could use the same type of technology out there. Do you have some ideas in this space?
So I have many ideas in this space. I want to first have us think about broadening the image chain, and that is the radiologist's responsibility shouldn't stop at the generation of the report. There are many, I call them radiologic care activities that go on after the report. So let's talk about incidental findings. I have a small lung nodule that meets the Fleischner criteria, needs a 3-month follow-up. If I send that report off to the physician who sent that report to me, I've now put a manual task on his list or her list, right? They need to, whatever mechanism they have, create a list, remember the list, create an order, call the patient, whatever. If we can automate that process, and I really believe this is purely a radiology phenomenon, so shouldn't it be just part of the radiologist's responsibility to bring that patient in, take a look at 3 months, say yes or no? And so can we use this tool to orchestrate the care of the patient, not just through this one imaging transaction, but through the continuum of their radiologic care, especially when that radiologic care really does not need any other type of clinician intervention. I think that would be amazing for all of us. I know the clinicians would love to be relieved of the burden of following up on whatever it is, lung nodules, a little spot somewhere, something in the liver, renal cysts, ovarian cysts, whatever. We've got the whole host of things that needed to be followed up. And, if we collect up the patient information, because usually there's some caveats along the way with the best practices, I think we could use this to manage over that whole course of care. And then the other area that I think is becoming very, very, it's just coming to top of mind for anyone that deals with POCUS, is the point of care imagers workflow. And there's a lot of concern going on about how do we make sure they've completed their workflow. And usually their workflow is a little hybrid between the modality, their workflow manager, and the electronic medical record, because oftentimes that's where documentation occurs. How can we use these tools to help make them more efficient and to help them know that at the end of the day, you still need to document on Mrs. Green, Mrs. Smith, and whatever other patient. So I think that's another area where we can start to automate and orchestrate workflow.
Very cool. Dr. Spencer, any final thoughts on these topics we've discussed today?
I think what we've got to look at as we go with some of these tools, ideas, and ways of working out into the enterprise is is whether more and more imaging in the broadest sense of imaging can be managed in the same way. I think those same tools that we've talked about for radiology can go beyond cardiology and support ophthalmic imaging, scoping images, OR videos, orthopedics and their templating, so that we get a more consistent output and that the imaging record fits alongside the EMR, the concept of the imaging health record. I think that the other place that will go, and I think this will be further and will further help radiologists, is that ability to mine data from the EMR in real time. So if you're dictating a complex report and you say a key word that triggers the AI to go off and curate information for you and present it while you're still reading, is going to enrich the quality and improve patient care. There's another area that I think probably applies equally both sides of the big pond, which relates to the fact that clinical teams are really focused on the part of care that they're delivering and not mindful of other care. So the EMR gives access to that, but we could also use these tools to make people aware. Do you realize this patient had a contact with the neurologist last week, or their diabetes has been poorly controlled? So that additional information feeds into whether it be the imaging occurrences and attendances, or be it part of clinical care. Because some specialists inevitably are focused on just the work that they're responsible for. I think that some of this also applies to things like making appointments more flexible for patients and using some smart tools that link AI to make sure that those things are appropriately prioritized. So I think this has got a very broad scope. I think that we're just really pushing off from this whole idea of orchestration. I think that North American healthcare facilities are probably further ahead with it than we are in the UK and parts of Europe, but I think it's all going to move at increasing pace.
Well, it's a very exciting future for sure. Dr. Petersolge, any thoughts?
So one thing I wanted to talk about, because I am really very interested in some work I hear coming out of AGFA, and that is this concept that I'm espousing and trying to raise awareness of the fact that the electronic health record and the electronic medical record are actually not synonymous, that the electronic health record really is comprehensive, consisting of all of the information about the patient. We have the electronic medical record, which is the textual representation of what goes on in the hospital or the doctor's office. And then we have this imaging record, enterprise imaging, whatever terminology your organization applies to it. And these are really peer systems, and they need to be tightly integrated. And seeing that I know a lot of people have integrated their viewer with the EMR, which is really phenomenal. And we know our clinicians drive all of their workflow and their access to the EHR through their EMR. And our producers really drive their work through the imaging record and its technology. And so how do we better make the information flow between those two systems? And with the new viewer capabilities that are coming from AGFA, having the ability for the clinician to send information to the image producer in their record could be extremely valuable, because information changes once the order's placed. So if we think about it, the order is really the main communication vehicle between the ordering physician and the image producer, unless you make a phone call, right? Which we know is a challenge for a lot of reasons. But if the patient's condition becomes more grave, and you could tell the image producer in their workflow in an automated fashion that this needs to be a higher priority for you, and then the orchestrator can adjust that delivery to the clinician, we've now made a great leap forward in how we're communicating. And again, better communication delivers better care to our patients.
Those are some really great thoughts. I want to thank you both for really participating in what I consider to be a very thoughtful discussion around not only orchestration, but really that broader smart radiology, that broader idea of bringing all of the enterprise imaging groups together. Very interesting thoughts from both of you in terms of really involving all the way down to the patient and how we manage that. Really some great insights there. I'm excited to see the imaging health record grow alongside the EHR, and I'm really excited for the ideas that you've talked about here today. Thank you again to both of you for providing your deep thoughts in this area, and I look forward to having more discussions with you again in the future.
Thank you, Paul. It was a pleasure to be here.
Likewise, I've really enjoyed those discussions and look forward to further engagement.
All right, so visit us at RSNA. We're empowering imaging without barriers. AGFA Healthcare, we're at booth 2552. Reach out for more, book a meeting. We're looking to show you some of the great concepts that have been discussed today and excited for the orchestration of the future. Thank you.
Thank you for joining our session and our webinar today. We're just starting the Q&A session here with Dr. Peter Silge and Dr. Spencer. So a couple of questions have come in, so I'm going to feed them through to our panelists here. So first question comes from Ishmael Hassab. I have a remark that radiology technician seems not to be valued in the world, and I don't know why. Perhaps, Dr. Spencer, you can speak a little bit to the radiology technician in this world of orchestration.
Sure. Hello, everybody, and it's good to be here with you today. I think the first thing, as somebody based in the UK, is that the appreciation of different professional roles is somewhat different, and the radiographer role generally in the UK can be almost anything, and that extends to reporting, autonomous practice, and all sorts. But in the context that we're talking about today for workflow orchestration, if you take a look at AGFA's enterprise imaging product, it's got different modules that are designed for the different members of the imaging team, from the front of house staff managing appointments and patient attendances, through to the techs acquiring studies, techs or radiographers. And then, of course, what we traditionally think of as workflow orchestration relates to how stuff moves around to the radiologist and whoever's reporting the studies. So I think it's fair to say that EI does have tools that, for example, can enable the technicians or technologists or radiographers to prioritize workflow. So you can manage tasks and move those around according to the availability of scanners, the availability of staff. You could do rostering and other workflow stuff. And of course, behind that, the business intelligence enables you to see where your best working, most productive areas are, and where you can find additional capacity. So I think the idea that radiology technicians are undervalued, I think that's a sad position, but one that I think can improve. And certainly with the technology that we've got available, we can make that work and that workflow easier for all members of the imaging team.
Yeah, and a big part of that, Dr. Spencer, is whenever we have the types of technology that basically distribute tasks to these various actors within the organization, it allows for us to actually use these tasks to feed each other. So the idea is that whenever we're trying to orchestrate and build the correct workflows within that orchestration engine, you can have things where a tech entered information can be fed into the orchestration queue and also have feedback back to the technologist as part of that orchestration queue. So it's a really important thing is that we have specific functionalities that allow for us to feed back to the technologist anything that is a challenge between the radiologist and the technologist. And that actually feeds through the orchestration workflow. So the idea is having these two roles intertwined with each other is very important. And I cannot be remiss to say enough that as the technologist is working through the solution, a lot of radiology orchestration solutions that are out there on the market today do not actually consider those different roles. So it's something to really look at whenever you're assessing a technology. So,
and even if it's something simple, just like the collaborator tool inside enterprise imaging, you can have that for all your workers who are online. So we will perhaps get into the conversation about interruption of workflows, but these things enable people to be much more efficient in their communication. You know who's available, you know who's online, and if a radiologist has protocoled a study but isn't online, then their peer who is online may be able to answer the question. So I think it works both ways, and And that communication between members of the team is really important to build the value in the team. And I think that perhaps also goes back to the comment made by the participant.
Great. Thanks, Dr. Spencer. Another question that we have here is, who determines what is priority? And perhaps Dr. Petersil, you'd be able to answer that question.
Certainly. So always a concern, because every organization prioritizes their work differently and has different goals that they need to make. And so it's really important that solutions can be tailored to whatever you determine is of value, whether it's the output of an AI, whether it's meeting SLAs, whether it's distributing work based on RVUs or whatever other metric you choose. So that's the beauty of a solution like this, is that it's really fully customizable. It's not that someone has already predetermined that these items are most important in determining the workflow for whomever. As we've been discussing, we might all originally go right to what is the priority for the radiologist in their reading workflow, which is, of course, extremely important, but we do have lots of other people on the team. And so what is the priority for the technologist? What do they need to be doing next? Possibly what patient do they need to be imaging next is really important. And then some of the things that we can feed into that are, what else is going on in the context of that patient? Do they have a nuclear medicine study to follow their CAT scan? Do they have a doctor's appointment to follow the CT? And so should that patient be imaged first because their appointment's coming up, and then they should be read next because their appointment's coming up? So lots of different things that we all account for on a daily basis. And actually, we, in my practice, oftentimes rely on our technologists to impart some of this information. Like, can you read Mrs. Smith? She's on her way up to see the oncologist. Whereas now that can be just automated right into the workflow, which frees everybody up to do higher value tasks. So again, it's really up to the organization to decide what is a priority. No preconceived notions about how you work.
Yeah, that's an interesting point, is thinking about how all the team works together to determine what the priority is. And it is actually a really exciting part of this technology going forward. And we think about that all the time, is, how do we weight things? How do we put the right things in place for these types of care scenarios? And I think what happens as a result of having that scenario is that we can really consider the entire care team in determining that priority. And that's a really important part about this, is I see from various institutions that often the clinicians and the emergency physicians and others that are involved in working with the patients, they have specific metrics to meet, right? So we don't want to have patients awaiting to be admitted to the hospital because they're waiting on a radiologist report before they would admit the patient, right? So there's all sorts of scenarios where we may want to have input, and live input for that matter, coming from the care team to actually drive that priority, which is a really interesting thing to think about. And Dr. Spencer, you had some comments here as well.
Yeah, I think that this is where the whole workflow orchestration piece gets really interesting. We are where we are today, but we've also got to anticipate that those won't necessarily be the phone calls that are telling us something is a priority. That'll be automated because the systems will be talking to one another and will be curating. So our interoperable systems, particularly maybe between the EMR and the imaging health record, will be saying Mrs. Smith is coming then. So you'll have that. It's almost like a prefetch requirement for report, which we're very familiar with in radiology. But that's got to extend out to the enterprise. And some of that we covered in the discussions we had during the webinar. But this is going to get ever more sophisticated, and AI is going to feed into it, and system integration between different systems is going to make it better and better. We've just got to make sure that the data is safe and that quality is assured, which is another important topic.
Absolutely, and we have another question related to that. Maybe Dr. Petersil, you could handle this question. What are the things that help us discover the right technology for this type of orchestration?
I think this is so timely as we're all getting ready for RSNA. And, going to RSNA can be like drinking from the fire hose because there is so much new technology out there. It continues to explode, especially now that we've added in this AI layer, right? And I think we just need to go back to the basics, back to my engineering training, defining the problem. So, there's two ways to approach looking at technology. That's like, tell me all that you got. Tell me everything you have to offer, which is fine and great. And that's really part of the learning experience. And we should all participate in that. And we should know what the market has to offer. But when we're choosing the right technology for us, we need to know, what are our problems? What are our pain points? What do we need to be solving for in our organization? And we should be very, I call it deliberate decision making. We should be very deliberate and very defined in the problems that we need to solve. Goes back to the priority question. We define our priorities, we define our problems, and we choose the technology that is going to best fit our needs. We don't want to be Mr. Shiny Penny who is chasing every new technology that comes out, because deploying technology for the sake of deploying technology is not going to be in the best interest of anyone. Healthcare dollars are precious dollars, and we need to make sure that they are allocated to the most appropriate resources to help our organizations achieve their goals. And that starts all the way from the top of what does our enterprise want to accomplish, all the way down to what is our radiology or cardiology or other imaging producing department being asked to do to help our organization meet those goals and take care of our patients. I see you smiling, so.
It's an interesting thing. Maybe we need an orchestration engine for healthcare IT buyers, perhaps, that helps them make their decisions. I'm sure that you're doing that yourself in your own role today as a consultant. However, in the future, it'll be important for them to be able to make those right decisions. So great points there. Last question here for Dr. Spencer. How can I trust that this automated system can give me the right workload?
I guess we've already touched on this a little bit when we talked about curating of work for the radiographer or technologist, based on what's available, what equipment's available, based on what staffing are there. But if we look at that managing the right workload, the orchestration engine in the workflow orchestration engine in radiology can take the schedule of the reporters. It can see who's online. It can see who's got a big queue of unreported cases, and it can facilitate and take some of the pressure off. It can know that the radiologist is logging off in half an hour, and it can stop allocating new cases. So there's the scheduling. There's the matching workload with who's available. But in addition to that, you can curate it by specialty or subspecialty. You can have agreed allocation as part of workload planning. You could do it in the same way for residents and trainees in terms of how much gets allocated for second reading, for things like peer learning and that kind of stuff. The amount that gets second read could be proportionate to certain parameters in the department. So we talked about configurability in some of the other topics we've discussed. And I think that for the questioner, in terms of how can I trust the system, it's part of the change management process that's going to go on whenever you deploy new IT systems. Cheryl's talked about not deploying a new IT system just for the sake of it, because it's a huge change management piece that you've got to do. But if you get buy-in from the team, you work out the capabilities of the system, you work together to enable the evolution of the system to get more sophisticated, and you work in partnership with your team so that people are not disenfranchised or feeling like they're being put upon. All of those things are likely to give a solution that's most likely to work in the end. So we've been talking through the last 45 minutes about amazing technology that's available here and now today. we've also talked a little bit about curating that with other systems like the EMR and other healthcare records. And all of this feeds together to give the opportunity for the radiologist to do their best in terms of quality and efficiency, to give of their best in terms of their opinions, and ultimately, as Cheryl's talked about, meet the organization's requirements, which at the heart of it is good outcomes for patients. So I think these are all positives that we just need to work through together.
And I'm going to just put a little plug in here for something that's near and dear to my heart that underlies this making automation work, and that is data hygiene. And it's something everyone does not like to talk about and does not like to tackle. But the cleaner your data is, the cleaner your metadata, the cleaner your workflows, the more standardized, the more efficient and effective these automated processes are going to be. Whole nother webinar, but again, that underpins making all of this work the best it can.
Great. So that basically wraps up our session. I just wanted to thank Dr. Spencer and Dr. Pearsilge for all their insights into the world that we're talking to moving towards with orchestration. And thank you all again for joining us on this wonderful webinar. Come see us at RSNA. We're all going to be there. It'll be a good time. And we're looking forward to seeing all the great new technology that's out there and talking about some of the problems that you have to solve. So come visit us. Thank you.